do this as a double act. So this was always going to be a very small audience of people. I suspect we've got some people online as well. And I've never spoken about men with PBC. I've never been asked to talk about it. And I think that's a really interesting question. So I've literally only got 2 slides. There's not lots of data. And I'm just going to talk about our take on PBC in men. So the challenge, I managed to get in the way, even though there are only a small number of people in the room. Right. So kind of the background to this. So 90% of PBC patients are women. Okay, so that's the starting point of this. But 10% are men. So it's a really unusual skewing of a disease without it being a total skewing, if you like. Like, for example, we'll come to it all. So it's really interesting because it's not 100% women a pregnancy-related thing would be, okay? So it's not absolutely women, but there is a clear skewing. So that's the first thing. The second thing is every aspect of the disease in terms of its blood tests, AMA, biopsy, etc., is the same in men and women. Okay, so there is no difference in AMA, no difference in biopsy appearance, no difference in the profile of blood tests. So it appears to be, in that sense, exactly the disease process. So it's the same disease process. So it's different in terms of its numbers, but it's the same when it happens. So the next one is the point I was just making, is that we are forever talking about genetic risk factors and environmental triggers. So an obvious thing would be an environmental trigger that is unique to women, such as pregnancy, and that clearly can't be the case. There is very little actual data on men with PBC. So in the UK, we probably have the best data because of the UK PBC cohort. So we have around about 8,000 people who've joined that over the years, and we have about 600 men in it. So you start to have useful data with a large number because you start with a very large number. But most of the kind of studies that are looked at men often have tiny numbers of people because they're in sort of a single center cohort. So what I'm going to show in the next slide is what I think we know about men with PBC. So it's partly based on the data. That's partly based on the data and partly based on my experience of it from the clinic. Do you want to go? You can sit yourself down now. You've performed. Jenna has performed her essential role. So what do we know about men with PBC based on the UK PBC study and based on our observation in the clinic? So the first thing is men are diagnosed later than women. So there is a delay to diagnosis that is quite significant. And I think, unfortunately, this is because of assumptions about why men get liver disease. So there is a general risk always with PBC that people always assume it's alcoholic liver disease because unfortunately that's what doctors do. Receptionists, in my experience, are the worst of all, that they make assumptions about why you've got liver disease. And I think that is true for all PBC patients, but it is particularly true for men. And there is a profound ignorance, I'm afraid, amongst GPs about the fact that men get PBC. And I think that's the reason why it's diagnosed later. The flip side of this is that men are more likely to have advanced disease at diagnosis. So if the disease is the same and you diagnose it later and it progresses over time, the corollary of being diagnosed a little bit later is that you are perhaps more likely to have advanced disease. Although that's not a dramatic effect. So that is not particularly an issue around cirrhosis or anything, but just typically it's been around, it'll been around for longer. So men are less likely to be given URSO to do with, I think, the assumptions about alcohol. Although actually that's ironic because urso is probably beneficial for alcoholic liver disease anyway because of the way it works as an antioxidant. So there is no reason at all, if you're suspecting PBC in a man and you think it could be alcohol or PBC, there's no reason not to give urso. It's useful for both of them. But just to put the whole alcohol thing to bed, there is literally no association between alcohol and PBC at all. You don't get AMA in alcoholic liver disease. If you've got abnormal liver blood tests and AMA, you've got PBC, irrespective of anything else. So men are less likely to respond to urso therapy and less likely to have got it in the first place. So why do men respond less well? I suspect it might be a little bit because they've got more advanced disease, and we know that the earlier you use urso, the more likely you are to respond to it. The good news is that there is no evidence at all that men are less likely to respond to second-line therapy. So I suspect what's going to happen is that men may end up more on second-line therapy, and that's no bad thing because there is a sort of a sense you can detect from all of this that we should be. There's a tendency for us to all think about urso as the treatment for PBC, and then for a tiny number of people who don't happen to not respond to that, there are other treatments. I think we need to be much more open-minded that actually I suspect over time the majority of people will end up on double or triple therapy. So it's whether you need 1, 2, or 3 agents. And anybody who's got high blood pressure will recognize that sometimes people are on 1 tablet, sometimes people on 2, sometimes on 3. There's no kind of debate about that. It's just what you do. And I think we need to move away from this sense that second-line therapy is unusual or special in some way. It's just standard therapy. It's whatever you as an individual need. So I think over time, men are more likely to end up on second-line therapy, but that is a good thing, not a bad thing. Now, interestingly, one thing about urso non-response, which is an interesting one, and I'll come back to your question, which is what are men doing right, is if you look at women with PBC, the younger you are at the presentation with PBC, the less likely you are to respond to urso. So if you present at the age of 80, if you get your PBC at 80, you are something like 95% likely to respond to urso. If you're a woman, if you present at 20, it's down at around about 30%. Okay. So there is this really strong age effect in women, but there is no age effect at all in men, at all. So you are exactly the same, you have exactly the same likelihood of responding to urso. The point at which absolutely it's the same at every age. Now, if you draw a graph, so women responding, the amount that respond, it goes like that, and men it goes like that. It's completely flat. The point at which those lines intersect is the age of 55. And we think at the heart of all of this is the role, particularly in women, about estrogen worsening the disease. So I think PBC is a disease of the irritation of the bile ducts, which leads them to be senescent. So anybody can get PBC, but I think when there is a high level of estrogen, it makes it worse. And so premenopausal women are therefore the ones who have worse disease because they're the individuals who have the highest level of estrogen. So what we are seeing in men is the background rate of PBC. What we're seeing in women is the background rate of PBC with the additional effect of estrogen. That would be my best guess. And I think we have never, ever seen PBC in anyone under the age of 80. Never seen it. Now, that might be the same effect as we see with men. If you make assumptions that all liver disease in men comes from alcohol, that all you see is alcoholic liver disease. If you assume that PBC doesn't affect children, you won't see children with PBC because you won't look for it. Having said all of that, talking to really good liver specialists in children, they genuinely never see PBC. They do see autoimmune hepatitis. They do see PSC, which are the first cousins, but you never see PBC. I think that's because PBC is triggered in women around about the age of puberty, and then is particularly driven by the high estrogen levels. And then post-menopausally, if you develop PBC, you've rather lost that that estrogen driving effect, and so it goes back to the baseline a little bit. So I think PBC, the sort of risk years of PBC are the years of high estrogen levels, which is in women post-puberty, pre-menopause. I suspect that's what's going on. Why does estrogen make PBC worse? Well, the bile duct cells actually have estrogen receptors on them. So actually, I think estrogen has a direct effect on the way in which the bile duct cells respond to injury. That's my personal best guess. A few years ago, we wrote a paper, just a report of, I think, 4 women who we'd managed with PBC, who were all taking tamoxifen for breast cancer prevention. So they'd had breast cancer treatment and they were giving the drug tamoxifen. Now, tamoxifen blocks the actions of estrogen. That's how it works. And in all of those women, their liver blood tests returned completely to normal when they took tamoxifen. It's very interesting. So tamoxifen appeared to normalize liver blood tests in PBC patients. Now, that was all long before second-line therapy, and it's been completely forgotten about. But filed away in that might be interesting to look at, would be the actions of drugs like tamoxifen in women, because they may well actually completely affect this differently. Why else are women different? Well, the immune system responds to estrogen as well. So there are 2 cell types in PBC that are estrogen receptive. One is the cells of the bile duct, but the other is the cells of the immune system. So why does your immune system have estrogen receptors? Well, it's about pregnancy. So a baby, if you're pregnant, is more different to you, because it's half the father genetically, is more different to you than a kidney transplant is. And yet you can't have a kidney transplant survive without powerful drugs, and yet pregnancy happens all the time without those drugs. So the immune system has this incredibly sophisticated way of responding to pregnancy to turn off immunity, and that's estrogen driven. And so that's the other aspect. And we often see with conditions like PBC and autoimmune hepatitis, the disease is actually very good during pregnancy. It all goes into remission. And then post the delivery of the baby, it rebounds. And particularly with autoimmune hepatitis, it can rebound quite aggressively. And you just never see those things in men. So it is quite estrogen responsive. For those of you who, like the history of medicine, are interested by it. So lupus is another type of autoimmune disease that affects joints and kidneys and things like that. And it's a horrible condition. And it's now treatable, but 50 years ago it wasn't. When it was first diagnosed in young women, the medical guidance was to get pregnant and get re-pregnant as soon as you possibly can after you have a baby, because that's the only way to prolong your life. It's quite extraordinary that the medical guidance was to be recurrently pregnant. Immunosuppression is really good compared to that. But I mean, it's a well-recognized medical fact. So I think men, it's worth remembering, of course, all men have estrogen in their blood and all women have testosterone. This idea that men have testosterone, women have estrogen, we all have both. It's the balance between them. And I think just in women, there is an estrogen responsive aspect with higher levels, and in men, it's the baseline. That's my personal theory. And I actually think that the reason why men do well with all of this and have less PBC is simply because they don't have the high levels of estrogen. So that's a really interesting question. I think there's no evidence that there is any difference in estrogen levels. There are very few situations where men have higher estrogen levels or are given estrogen.
because obviously, is it not true?
Yes.
These fingers is dictated to by how much insulin, sorry, how much estrogen or the other hormone, the male hormone, testosterone, is relative to those fingers in gestation.
So that's a really yes. So that's a really, really interesting question. The question here is, yeah. So the question here, just to paraphrase it, is that of course the time that males are exposed to high levels of estrogen is in the womb, when the mother's high levels of estrogen are around. So the question is hormonal balance during pregnancy important? And I think that's an incredibly good question, and I don't know the answer to it. However, what I do know is I was talking to Catherine Williamson this week. So for those of you who've never come across her, she is probably the world's leading expert on pregnancy and liver disease, and she has a particular interest in PBC, and she is very interested to work with all of us around the reproductive aspects of it. And I'll get back to her and say, should we be studying? Yeah.
Gestation, and obviously the thing.
Yeah. Yeah. So that's a really good thought. I'm not aware of any data at all on it. Okay. But we can certainly look at all of that. Yeah. We were talking about that. It's urso dilates the lower esophageal sphincter. So it's the urso and contributes to reflux. Yes, so it's a reason to move to obeticholic acid, which is something you can give for people who are intolerant of urso. So obeticholic acid would be the right thing to think about. So we'll just continue with this. So urso. So I think it's a really interesting question. We look after the only person in the world that I am aware of who is somebody who is AMA positive with a family history of PBC, who was a female to male transsexual. And the question was, what would happen to somebody with a predisposition to PBC who had normal LFTs but AMA when given testosterone? And it's very interesting. They went on to develop PBC at exactly the same rate we might have predicted otherwise. So I don't think this has impacts on therapies. I think it's just an observation. Now, the next one is really interesting, is very clearly in the UK data, men are less symptomatic with PBC than women, very clearly across a whole population. Less likely to have itch, less likely to have fatigue. Okay. Now, one could make comments about male fortitude and various different things like that, but I wouldn't do that, mainly because Jenna would come and hit me, I think. So why do men get less fatigue? Well, it's interesting. It's to do with regulation of blood pressure. So one of the things that we've talked about, you saw when I talked before about the autonomic nervous system. So the autonomic nervous system is the part of the nervous system that controls your blood pressure, controls the fact that you don't keel. I mean, not a great indication for me falling over when I try and sit down, but normally when we stand up, our blood pressure regulates itself so that we don't black out. That's your autonomic nervous system, and that works poorly in PBC. So you don't adjust your blood pressure when you stand up, blood pressure can fall, the body produces adrenaline. So that's part of something that's common in PBC. And we know that drop in blood pressure leads to poor perfusion of the muscles. You've heard me talk about acid in the muscles. You heard Palak talk about acid in the muscles. Part of the effect for acid in the muscles is that the blood just doesn't get to carry it away. It all sits in the muscles, and that's to do with the autonomic nervous system regulating it. Men have normally higher blood pressure than women. Okay, so across the population, on average, all men have higher blood pressure than women, and that higher blood pressure seems to be protective against getting these symptoms, because you don't get that hypoperfusion. So, in fact, if you correct for the blood pressure difference, so if you look at difference in fatigue between men and women, if you correct for difference in blood pressure, then that accounts for it. So it's simply that men run a higher blood pressure. And one of the things that we do practically in the clinic around fatigue is to not artificially put people's blood pressure up, but to look at those factors in women in particular that lead to them having a lower blood pressure and adjust for all of those. And it actually makes quite an important difference. And it's very common in women to get nighttime dizziness, or, you know, just before lunch to be a little bit dizzy when they stand up. That's because women run much lower blood pressures than men. We men hear all the time about women's health as a major issue, but men die on average earlier than women. So in reality, we should be talking about men's health, not women's health. But there you go. That's just a thing. So less likely to be symptomatic. I think this also may contribute to diagnosis being later, because the most difficult group of people with PBC to manage are the ones who have no symptoms whatsoever and never go to see the doctor. Now, men are typically a little bit like that. It's well known that men are less good than women at seeking medical care. You're also less likely to have those sorts of clinical kind of interactions where your blood test will be checked automatically. So a pill check or pregnancy are times people have their liver function tests measured, but men tend not to have those. They tend to get blood pressure, you know, or well men clinic a little bit later in life. So if nobody's measured your blood tests and you have no symptoms to go to the doctor, then you're not going to be diagnosed with PBC. And pretty much all of the people we see nowadays coming to our attention who need transplant, there are a legacy of people, you know, who came through the system in earlier years. But the problem group we see now are people who present needing a transplant. They come through the door on day one and they need a transplant. And those are almost always entirely asymptomatic people. And it's just because nobody has spotted it, because nobody has looked, because there was no reason to look. So it may be that the symptoms are why it's diagnosed a little bit later. So this is an education thing for doctors to be aware of it. The point is, in terms of our treatment approach, whether you need URSA or second-line therapy, you respond exactly the same as women. So you can have all the benefits of therapy, but as I said in my previous talk, you can only benefit from therapy if you get therapy, and you can only get therapy if you're diagnosed. Now, the next one is an observation that, and the next two are really run together. I think it's very important, is that men often feel out of place in a PBC clinic, and I'll be honest, in patient groups. So when we're having a session about men with PBC, 95% of the audience has gone, and that's because they're women. And so therefore, this feels kind of a lonely place. And I've certainly had lots of people talk to me about that. We have a dedicated PBC clinic, and we would see one man every other week in the clinic on average. And so that man coming and sitting in a waiting room full of women is going to feel a little bit strange. Doctors don't help, and the internet doesn't help, with the implication that this is a disease of women. It isn't. It's a disease that affects both men and women. It just happens to be commoner in women. But much of the way this is talked about, much of the way this is described, has this implication around women, which is just odd for men. You know, have I really got this? When we did the PBC 40, the development of it as the symptom questionnaire, a number of men who completed it kind of said to me, I don't really understand this. This is about me. I don't really understand this. None of this relates to me. And of course, when you derive it, the questions come from the words of patients. So the words that were used in developing it were the words of the average PBC patient. That average PBC patient was a woman. So it's just a different disease to have with men. And I actually quite like looking after men with PBC, because I think I get that, and we talk about it in a slightly different way. But we've just got to realize that younger women are very different to older women. Men are very different to women. We have to make the care that we offer suitable to everybody with this condition. So we do look after lots of men, but I get this, that it sometimes feels that you are almost excluded from it. And I think we need to understand all of these issues and ensure that we focus on the detail. And I think we need to look quite carefully about the literature and the way in which we talk about it to make sure that it resonates with people. I think, for example, with the book, the second edition of the book, which came out earlier this year, we have got a whole section of what it's like being a man with PBC, which we didn't have in the first one. It was partly to answer all of those things. So what do we know about men with PBC? It's real, it exists, it is biologically the same in everybody. There are issues about late diagnosis, late starting of therapy, and response to early therapy. Those all, however, catch up with second line therapy. So in terms of management, you need to do exactly what we do in everybody else. There are some really interesting questions it gives rise to about why people get PBC, because it's nature's little experiment. People are less likely to be symptomatic, which is a good thing, but that can have a knock-on effect for diagnosis. And men can often struggle with the diagnosis and feel out of place in the services that we offer and in patient groups. And I think it's really important for all of us to understand that. And I think it's important for doctors to understand what's going on. So that in a nutshell is what we know about men with PBC. And it's a really interesting question. Yeah.
Is there any relationship between asthma and PBC?
There's no link with asthma. So the conditions that are associated with PBC, it's not all immune conditions. So asthma and eczema go together, and those are not associated with PBC. Psoriasis, lupus, scleroderma, those are the conditions that are associated with PBC. However, you've got to, with associations, obviously, where you've got conditions that are common in the population, you will see the combination more commonly. And so it's all about the statistics of it. So, and these need large case control studies. So asthma has been specifically looked at like eczema has. And what you do is you take 2,000 PBC patients and 2,000 age sex match controls, and you look at all of these things, and you look at the frequency of various different conditions in them. Now, you even have to be quite cautious with that. I talked about vaccine recollection yesterday. I don't know anybody with PBC who doesn't know what vaccinations they had, but other people don't because they ask about it. So you can have a recollection bias with it. But you've got to do these studies using the correct approach. You've got to match for social class and background and ethnicity and things, because there will be different effects. And I'll tell you a story about that. There was a theory that went around a few years ago that PBC is caused by an effect of hair dye. So hair dye molecules getting into the bile duct and then having an effect on the bile ducts, okay? And this theory was put forward by various different people. And you take a step back and you think, well, hang on a second. Here's a condition that's commoner in women. Women are more likely to dye their hair. All of a sudden, you've discovered something that is commoner in women, but not automatically in women. That sounds like a really good idea. And then you get into this reinforcement bias. So every time you come across somebody who dyes their hair with PBC, it makes you more convinced it's right. And every time you come across somebody who doesn't dye their hair, you kind of, well, they probably dyed it at some point. So that's that recollection. I was saying yesterday about what does AI offer in medicine. Well, one of the things it offers is it is not biased by previous recollections. So anyway, there was this theory that was out there. So we developed an approach which we called a best friend analysis. So we asked patients to recruit their best friend in the same gender, same age as them, who lives closest to them. And so that was a good way of getting controls who are matched socially and geographically and everything else like that. So we did a big study looking at a whole number of these factors, and one of which was hair dye. And we sent all of these out, and when they all came back, we split them into, you know, the white ones were from patients and the yellow ones were the controls. We split them all out. And we thought, let's analyze them. So we went to the PBC ones first, and it was hair dye, hair dye, hair dye. And it turned out that 70% of PBC patients used hair dye. And you looked at all of this and you thought, well, there's the answer, right? It's hair dye. And then we did the controls, hair dye, hair dye, hair dye, and 70% of the controls used hair dye, okay? And what this told us is that no men understand about women and hair dye. Okay, it's a conspiracy. None of us know about it. It's happening there, and everybody does it. No, but there's a serious point: is that, gosh, 70% of people. It's such a strong thing, but of course, it's a population level thing. So it's all about study design, and you just be very careful. You see a lot of science in the news, which is this rather naive level, which is a gosh, what a lot type of thing. And often it's to do with you don't really understand what happens in the broader population. Yeah, so yeah.
I'm glad that you told me definitively that there is, because I have severe.
Yeah.
That also maybe.
Yeah.
More than likely.
Yeah. Yes. Yes. Yeah. So. Yes. So when you're looking at diseases, always think of there can be a connection through the causes of a disease. So a genetic thing. So one immune disease associates with another immune disease. So that's a connection. There can be a connection through the disease itself. So itch and PBC are linked because PBC causes itch. But you could also have a link through the effects of treatment. And so side effects of treatment, if that treatment is only given in a disease, then a connection between two diseases can come about because the treatment for one disease causes the other. And I think that's the one that doctors often forget, is that you put it down to the disease, but it's actually is the disease because the disease led to the treatment and it was the treatment. And Urso is a great drug because it's safe, it doesn't hurt people, but it causes GI disturbance. It causes high mobility in the gut, which can give you fast, lower, bowel looseness, and it can give you reflux because it dilates the sphincter at the base of the esophagus. Yeah. Yes, I think so. I think one of the things that PBC, the field, has slipped into, and it's done it in the past with Urso, and it's in danger of doing it again with bezafibrate, is to think that certain things are the definitive answer. That's the answer. And we saw it in Urso, and for many years, people said, why do you need other therapies? Urso is everything you need. And what we now know is that Urso clearly works, but it works in variable degrees in different people. So you need something else. And that argument is now well won. Now there is an argument by some people that all you need is bezafibrate. Okay, that's all you need, and so therefore we don't do any more trials, don't do any more drugs because bezafibrate is the answer. Interestingly, they're exactly the same people. So it's the French group, Corpechot and colleagues. They were the ones who argued that Urso was all you needed, and now they're arguing that bezafibrate. And I know them very well, and I have pointed out to them that I thought you thought that Urso was the answer, and now it's bezafibrate. So I guess Urso wasn't the answer then. And the answer is combinations. And I think that's the whole point. So the answer is all of these things are part of the answer. We all want there to be an answer, but the answer is that these things are all part of the answer. And it's increasingly going combinations, as you say, and it's understanding those. And I think it's 1, 2, and 3 is going to be the way to think about it. Yeah, go on, sorry.
Surely, in terms of case people, heat probably the disease would probably be male. because the male is different in the subsets. In other words, I mean, the difference between the male and the you know, of course, the disease become prevalent in the female indicate, you know, give you a lot of pointers to where the disease is going to be, with, you know, what the triggers are in terms of, you know, how things develop. So
Yeah.
if you're a male, you can identify why that male is more likely.
Yeah.
It's almost that might be the
again,
combination, right?
again, that's a very good point, is that, as we were saying, but the female state adds complexity to it, whereas the baseline, the male PBC rate is the kind of rhythm, and the female is the melody that goes up and down and doing all of that. Yeah, yeah. Yes, yeah. The really interesting question, of course, is that we talked yesterday about mining activity and cadmium in the environment as a geographical risk factor, absolutely robust in statistical terms. But that's weird when you then think about the gender base, because clearly,
just quite funny, we've discussed in this day, you know, these types of these things. My personally, Claire's kind of research, you know, PBC is Claire.
Yeah.
Sisters don't.
Yeah.
However, sister, Claire's always suffered from low blood pressure.
Yeah.
Which is an interesting thing. Another thing is, you know, I was thinking about, obviously, we're talking about cadmium. Cadmium is available in the well, in a lot of Europe, people have endometriosis, or what it is, that disease. And both the sisters actually have.
Yeah.
So
yeah.
That they are also expressing cadmium, if you know.
Yeah. Yeah.
This just to me, there's more.
One of the weird things about the environmental stuff, just going back to the needle in the haystack, is that if you look in Newcastle, they do a lot of water work. So if you really want to find out it's the environment, you look at the water runoff. So some stuff was known about COVID in relation to that. And if you look at the soil in Newcastle, Newcastle itself has very consistent pattern of soil. But if you look immediately next to the River Tyne, it is completely different. So the combination of metals and things in the soil is completely different. And the pattern you see immediately adjacent to the River Tyne is that you see in London. Okay. Yeah. And what used to happen was that the coal ships used to pick up coal on the Tyne, take it all the way down to London, and then to come back up from London, they used to take River Thames mud on in order to get ballast. Okay, so to ballast the ships, they used to take mud from the River Thames, and they would then dump it by the side of the River Tyne. And all these years later, you can still detect that microenvironment difference. Weird, amazing, isn't it? Yeah.
I tend to agree.
Yeah. It's the red stream. We're all familiar with the red stream, aren't we? You know, you'll have a local stream which is bright red because iron is leaching off. And I think the thing about mine working is that you get a long-term effect. So it's partly there. So actually, when Jess, my colleague, did all of this, it is mines. The peak risk is associated with mines that were open in the 1960s. You can actually pin it down to when the mines were open. And of course, a mine, what's the natural history of a timescale of a mine? You open it up, you mine it, you bring out all of the waste and you put that out, and that rain runs through it all. And then you shut it down, and then you cap it, and then for many years they'll pump it. So there are still around the northeast pumping operations for closed mines, and then at a certain time point they shut down the pumping, and then what you do is you build a housing estate where the mine used to be. Okay. And go figure where in all of that the risk factor comes. One of my colleagues, so a guy called Steve Rushton, one of the things that I've done in my life, which is utterly fascinating, is to work with totally different people who do totally different things. So not just do what I do, but go and talk. So he's the guy who did the work around Sellafield and leukemia. So we're all very familiar with Sellafield and the risk of leukemia. And the work that they showed is that there is a leukemia cluster around Sellafield, but it's associated with schools. It's to do with children, and the fact that lots of different people came from different parts of the country, which meant that in the primary schools and the nurseries, those young children encountered viruses more in the way of viruses. So it was driven by viral mixing. Really interesting. So Steve is the one who did all of this geoepidemiology with us, and he showed a map for Teesside. So Teesside, very industrial, and then post-industrial. And he showed a map of how over 50 years, the heavy industry had migrated in Teesside. So it had migrated towards the coast. It was quite inland to start with, and it migrated outwards and outwards and outwards towards the coast. And he then showed a map which showed the migration of house building, and it was exactly the same as the migration of industry, but 10 years later. So 10 years after these factories and mines were shut down, they built housing estates on them. And that's one of the things that we wonder about is it things like brownfield house development? Are we kind of doing some things that in the future we might think are not the smartest things to do because it's previously contaminated land? So we think it's something like cadmium that gets into your circulation because it's there in the environment. There are probably genetic factors with it, and then it gets transported out into your bile because it's actively concentrated there. That's my personal guess. Just, yep. This is going to be the last question because I have to head off. Yeah. But the environmental stuff is just fascinating. Just fascinating.
And for example, is there anything that we can do, maybe change the terminology that we use so that men feel this is more talking to them? Or maybe I've noticed a lot of people and PBC are women, quite a lot of women.
I would ask them. I mean, I would ask them I would ask them how to make it more. It's only an observation. And I look at stuff, and it's sometimes very difficult to see, if you know what I mean, is that we've poured and poured over. So I've had multiple men who filled in the PBC 40 and said, have you given me the right form? This just doesn't relate to me at all. And we look at it and I can't see it, but it's a repeated observation. So I think the important thing is just to bear it in mind always and just think, how would this play, if you like? So there's nothing egregious in it all. There's no big problem. I think I'm sure the men here would agree, is we would all do anything we could possibly do to avoid any form of contact with a doctor. That's a male thing. And so the problem is it feeds into a resistance to do all of this. So why do men struggle to go to the GP, right? It's a well-known fact. But then I was thinking about this when I've got high blood pressure. I went to go and have my blood pressure done. I had a slightly surreal moment where there were two people waiting in the waiting room, the local GPs. One was me, the other was Alan Shearer. What do you do? Hi, Alan, how you doing? But I was looking around and it looks like it's designed for women and children. There are lots of things about cervical screening and lots of toys for the kids and all of that. It just doesn't feel a place where people who are a little bit resistant and women's magazines. And women are much better than men at seeking medical care, and it's much more of a normalized thing. And I see this because I am exactly that person. I'm resistant in I will act. I mean, and I'm a doctor. I would actively and I don't think a men's section is the right thing to do. I don't think male clinics is the right thing to do. I think understand that there is a natural resistance to do it. You naturally feel a little bit uncomfortable. You're going to find reasons not to do it, and just have a little think with all the things that we do, just to be aware of all of that. But it is a really interesting question. It's why you know, in a sense, there's more progress around breast cancer screening there is around prostate cancer. It's exactly the same thing. But it's, so I think it's just something interesting to bear in mind. But women are just better at this than men. Women are better at this than men. Right, with that.
Is equilibrate the only figure by the NHS?
No, it's phenethylgrate.
Which one would you recommend?